Hello students, welcome to week 1 lecture. I'm Professor Krueger and we are going to be going over the first 3 chapters that we covered in class. Um, I'm willing to provide this video to supplement your learning, so I definitely hope this is helpful for you. So let's get into that. So our first chapter deals with caring for the medical surgical patient. And there are some key terms that we definitely want to know to be able to get the most out of this chapter. So one of the first key terms is active listening. When we're with our patients in the room, it is so important that we not only use our hearing, but we connect it with our body language, what we're saying, what we're believing. And so being able to active listen to what our patients are saying, not only what they're saying, but what they're not saying. Many times for patients, it's a little difficult for them to express exactly what they're feeling. So when we practice active listening, that allows us to be better nurses, improve our assessment skills, and then be able to treat that patient appropriately. Another key term I want to talk about is empathy, being able to put yourself in the patient's position. When you're able to do that, you can go deeper into what the potential problem may be. And then with that, you're able to better find out ways to heal them. Yeah? Um, Another important key term for this first chapter is holistic care. Now, when we talk about holistic care, it has to do with treating the whole patient, not just their one specific disease or their signs and symptoms. So, with that first chapter, definitely want to talk about the different roles of the LPN. And with that, the LPN definitely, we're a caregiver, we are an educator, we're collaborating with the patient, their family, the doctors, dietary, the UAPs. When we talk about UAPs, that's the unlicensed assistive personnel. I think we call them CNAs here in Wisconsin. So, but if you see that word UAP, that's basically a CNA, an unlicensed assistive personnel. LPNs are leaders. They can be charge nurses. And as long as you have an RN at your disposal on a phone, LPNs can be supervisors, charge nurses, and definitely leaders of the long-term care facilities. Delegators, very important that when we're delegating is basically transferring transferring a task to the CNA, or you can delegate to another LPN too. But most of the time we'll be delegating to those CNAs and the UAPs. When we are delegating, it is very important that we delegate things that are appropriate for their skill level. So we can't delegate things like passing meds. We cannot delegate anything that involves the administration of a medication. That includes medicated butt creams, medicated lotions, things like that. We cannot delegate those. We have to know the limits of the person that we're delegating to so that we don't get into trouble and delegate something that was not appropriate, because we always think of safety first. When you're delegating, with everything in nursing, you always have to consider safety. Very important to consider safety. So, roles of the LPN were caregivers, educators, collaborators, leaders, delegators, and then advocates. Being an advocate for your patient is very important, because there's times when your patient cannot speak up for themselves and correctly communicate what it is exactly that they need. So very important that we advocate for our patients. That's really important. Some of the things I want to talk about with national patient safety goals. We're always thinking about safety. So national patient safety goals, those are safety goals on a national level. Um, we always want to use two patient identifiers when we are doing a treatment, giving a medication, things of that nature. And so patient identifiers, they can be wristbands on the patient, it can be a picture in the chart. Um, what else? Yeah, definitely the picture in the chart, the wrist bracelet, and then maybe if you're a new nurse and are unfamiliar, confirm with other people, staff members who have been there and know the residents that you're giving the correct medication and treatment to the right patient. Remember those 6 rights, very important. Another patient safety goal, improving staff communication. One of the best ways that we can provide holistic care to our patients is in communicating with each other. So that means communicating with our CNAs, communicating with the RN, communicating with the healthcare providers, dietary, maintenance, whoever. Very important that we improve staff communication. So being able to um, appropriately say what you need and what your patient needs. Very important. And that also involves listening. So not only communicating, speaking, but listening and receiving back the information that you are communicating with other staff members. Another patient safety goal, using medicine safely, using alarms safely, preventing infection. We have to know those signs and symptoms of infection so that we can notice it before it gets out of hand, because when an infection develops, sometimes it can be a little slow, but and sometimes the signs and symptoms aren't as clear cut. But what we want to do our best to prevent is sepsis. And so typically you'll get an infection, a localized infection. If that localized infection festers long enough, it can go systemic and go through the whole body. What else? Quality and safety. So we use evidence-based practice to increase quality and safety. Evidence-based practice is the latest and most up-to-date information that we use in the care of our patients. And when we use evidence-based practice, that improves the quality of patient care and can also improve safety. Informatics. Informatics is using information and technology to communicate and manage knowledge, and that helps prevent and mitigate error. So informatics, that is the use of data to be able to predict trends that may happen. When we can predict trends in healthcare, we can do things to prevent certain complications. So very important that you know what informatics is. As always with older adult, always know that with older adult considerations, we have to treat slow, start slow, go low. Older adults, they tend to be much more susceptible to medication side effects, so always start slow, go low, start low, go slow. So that was it for chapter 1. Also important to know that the Nurse Practice Act varies from state to state. Every state has a slightly different Nurse Practice Act. The Nurse Practice Act is what you use to know your role, know what your limitations are, because as an LPN, there are certain things that you can't do. And when we talk about going into chapter 2, the second chapter, critical thinking and the nursing process. We talked about critical thinking as being a method for solving problems. And when we apply that in a clinical setting, we get clinical judgment. Clinical judgment is the result of critical thinking applied to clinical situations. So you're going to be presented at times with critical thinking situations. There's going to be times where you have to prioritize certain things. And typically we look to the ABCs of, to help guide us. Always, if there's someone who is having respiratory distress, we are going to prioritize them first. So critical thinking, clinical judgment, those are very intertwined. When we talk about the nursing process, that equates to ADPIE: assessment, diagnosis, planning, implementation, and then evaluation. As the LPN, we're a bit limited. We have to be in close collaboration with the registered nurse. So you may hear sometimes that LPNs cannot assess. Well, in a way, what we're actually doing is collecting data to assist the RN in the assessing process. Now we go to the next part, diagnoses. And when we talk about diagnoses within ADPIE, we're talking about diagnosis of nursing diagnoses. So again, the LPN, we assist the RN in developing that nursing diagnosis. The LPN alone cannot diagnose by themselves. They have to collaborate with the RN. So we're still involved in the process. Planning, definitely LPN's very important in the planning phase, coming up with an idea of how we can counteract this diagnosis, how we can treat it. Now implementation, that's when we're carrying out the plan. The last part, evaluation, we're looking to see if what we did was effective. And if it wasn't effective, we come up with a new plan. If it was effective, we make sure that we chart that, and then we know that that plan and the implementation worked out pretty well. So that's ADPIE, that's the nursing process. When we talk about subjective data is what the patient says. Objective data is what you observe or can be verified by sight, smell, touch, and sound. Very important that we know our lab values. We need to know what's normal before we can determine what is abnormal. And we'll get into labs later in the semester. But I quickly want to go through Maslow's hierarchy of needs. Very important when you're looking at that pyramid, Maslow's hierarchy, it starts at the bottom at a physiologic level. And now physiologic level includes oxygenation, nutrition, which is food and water, elimination, bowel and bladder, safety, rest and comfort, hygiene and activity. Those are the basic needs. And before we can move up the pyramid, those levels, we have to be safe in that particular current level. So the bottom level is physiologic. The next level, safety and security. So that has to do with psychological comfort, assistance in meeting their needs, and then maintaining a comfortable environment. The more comfortable environment you can maintain for your patient, the more secure they will feel. The next part of the pyramid, love and belonging. As nurses, you need to open up your heart to love, and your patients will respond to you much better if they can sense that you have a loving, caring attitude. Very important. So love and belonging. Love, that's giving and receiving love, affection. Belonging. Belonging includes social interaction, communication, human caring, and then family and community. For some of our residents in the long-term care facility, the nurse and the staff there is their family, is the community. So we do our best to make them feel like they're at home. The next level of the pyramid is self-esteem. Self-esteem has to do with independence, competence, exploration, roles, motivation, learning, leisure, and spiritual beliefs. Granted, in the long-term care facility, many of our patients are advancing in age. That does not mean that they do not want to still be as independent as possible. we do our best to include them in their plan of care so that they can feel like they're in control. A lot of times with disease processes and as we age, we start to feel like we lose control over ourselves. So we do our best to promote self-esteem among our residents. At the top of that pyramid, important to know, not everyone reaches the top of that pyramid. It has to do with self-actualization, and that centers around self-knowledge and acceptance, achievement, openness and flexibility, universal knowledge, love that one, aesthetics, which includes artistic appreciation, and talent. And in my experience, I noticed that some of the people who suffer the most are those who did not reach that top pyramid. They never become fully self-actualized. So we do our best to meet the needs of those people too. They may need a little more loving and care. So one more chapter here for our week 1 lecture that stems around chronic illness and rehabilitation. We know that as our patients start to advance in their disease process, there are certain disorders that may cause immobility. And immobility is a big issue within healthcare. Some of the disorders that can cause immobility are multiple sclerosis, stroke, spinal cord injury, lower extremity amputation, head injury, multiple traumas, fractures of the knee, legs, hip, pelvis, or spine, certain neuromuscular disorders such as muscular dystrophy, poliomyelitis, cerebral palsy, myasthenia gravis, also congenital deformities. Congenital, born with it, it's genetic deformity. Burns can cause immobility, advancing cancer, advanced stages of Alzheimer's, dementia, Huntington's disease, and Parkinson's disease. Those can all lead to immobility. Also, rheumatoid arthritis, osteoarthritis, those are all disorders that can cause immobility. Now, what is the big problem with immobility? With immobility, when they're not moving, they are at risk for developing pressure ulcers, skin breakdown. When that happens, they can get an infection too. It can be painful for them, and that can be really bad for the patient and the facility. Also, when we're immobile, we can actually, the heart starts to not pump as well. Blood and fluids are not circulating as well. That can lead to a clot. We definitely want to try to prevent a clot at all costs. If that clot becomes dislodged and goes into the lungs or the lower legs or the heart, that can definitely be a big issue. So we definitely want to do our best to prevent those complications of immobility. Also, with immobility, the pain can increase, constipation can happen, urinary retention. So those elimination problems, we want to prevent those. So what can we do to prevent contractures? For musculoskeletal contractures, we can do range of motion exercises. For foot drop is where the foot tends to, with immobility, if they're not putting weight on their feet, their foot can actually start to drop. We call that foot drop. So to prevent that, we can do range of motion while in bed. We can use certain foot supports, and then high top tennis shoes. Osteoporosis. How do we prevent osteoporosis? Weight-bearing exercises, range of motion, ambulation. As far as preventing constipation, what can we do for that? We can increase their fluid and fiber intake. We can also do our best to increase their activity level. For our cardiovascular system, decreased cardiac output, we can help prevent that by doing range of motion exercises. To prevent venous stasis and clot, we can use exercise, support stockings, anti-embolism stockings, or those leg squeezers that we put around their leg. I think that's pretty good for now. I wanted to try to do my best to keep this video under 10 minutes. Oh my God, it's already 20 minutes. Good God. Okay, key points for that last chapter. Very important that we prevent the complications associated with immobility. We know that as our patient ages, or we're dealing with surgical patients, the chances for them developing a complication due to immobility increase. So we definitely want to do all the things within our scope to help prevent those. So this was the lecture 1 review. I hope it was helpful, and I'll see you guys next week. Thanks. How do I stop this?